Yes, so today we talk about cesarean section. A cesarean section is a procedure, um, a surgical procedure that is used to extract a fetus from the mother's uterus or abdomen. So we cut through the abdominal wall and get to the uterus and open the uterus and extract the baby from the uterus. So that's what a C-section is. Um, so a C-section is done for different reasons. So we have what are called maternal indications, and we have what are called fetal indications. Maternal indications would be something in the line of a mother who has a 3 previous cesarean section. We know that when we have a 2 previous cesarean section, a 3 previous cesarean section in our setup, we don't allow a woman to progress in labor and deliver vaginally. We have conditions like a mother who had a myomectomy, meaning she had fibroids which were removed, and we can't allow this woman to go into labor to reduce the risk of rupture. We have patients who have, for instance, an aortic aneurysm. All these patients, if they came in our labor ward, would not allow them to go through a vaginal delivery. They would end up with a C-section. Of course, a mother with placenta previa, the placenta is completely covering the os, the outlet, so this mother cannot go for a vaginal delivery. They end up with a cesarean section. Those are some of the examples. On the fetal side, we have things like fetal distress. We have things like cord prolapse. We have things like abruptio placenta. We have things like breech. We have things like macrosomia. So these are some of the indications for cesarean sections. We know that indications can be relative indications or they can be absolute. Relative indication means that it's possible to have a vaginal delivery, but we don't want to take a risk. Absolute means that it's impossible to have a vaginal delivery, like in a case of a placenta previa grade 4, it's impossible to have a vaginal delivery, so we go for a cesarean section. In a patient with a big baby, for instance, that is a relative indication for cesarean section, because we've seen mothers deliver 5 kg babies and deliver 4.5 kg babies. So if we say the indication for this Caesar is big baby, then that is an example of a relative indication. So the next thing we need to talk about is the new, not really new, but an emerging indication, which is C-section on mother's request. Yeah, this is an emerging indication. What C-section on mother's request means is that a mother comes to the hospital and there's really no medical indication for a cesarean section to be done for that particular pregnancy, but she feels that she wants to have a cesarean section for different reasons. Some mothers say that they want a cesarean section because they had a bad experience in the previous pregnancy. Sometimes there are other indications, like my other two babies' birthday are on the same day, so I would like all my babies to have the same birthday. So that's an extreme request from a mother. But the point is that the mother is the one asking for a cesarean section. The healthcare workers are saying, you can try vaginal delivery because there's no really good reason for you to go for a cesarean section. And normally in this situation, what we do is to counsel the mother. Counseling is important. We talk about the risks of cesarean section, the benefits of cesarean section, and if the mother chooses cesarean section after this, then she goes for cesarean section carrying that risk. If the healthcare worker is not comfortable, they can refer to another healthcare worker if they're not comfortable with the indication that the mother wants a cesarean section for, and somebody else can continue counseling the mother and probably do the cesarean section depending on the situation. So that's about cesarean section on mother's request. So the next thing is the types of cesarean sections that we have. What are the types of cesarean sections? The way cesarean sections are classified. So you can have what is called lower segment cesarean section, or you can have what is called a classical cesarean section. So a classical cesarean section is a cesarean section that is done in the upper segment of the uterus. So there's a uterus here. This is the cervix. This is the lower segment. So on this segment, the peritoneum is really easily mobile, so you can feel it. It's about 7 centimeters. That's the kind of like the length or the height of the lower segment. So when we cut in this area, whether we cut transverse or we cut vertically, as long as it's in this shaded area, what we have is a lower segment cesarean section. If for some reason we cut in this area, whether the incision is transverse or vertical, this is what we call a classical cesarean section. So a classical cesarean section is risky because it has a high risk for rupture. So if you have a classical cesarean section, that woman is not going to have a vaginal delivery in the next pregnancy. If you have a lower segment cesarean section, this woman can have or can attempt a trial of vaginal delivery in the next pregnancy, because we know the lower segment is thin, it's not very well supplied with blood, so the amount of bleeding that you experience when the woman experiences when you have a lower segment cesarean section is much lower. In the upper segment cesarean section, we are cutting through the thick muscle of the uterus, and therefore you have to suture through many layers, and there's weakness that remains in that area, and therefore the woman ends up needing a cesarean section in the next pregnancy. So that's one way to classify cesarean sections. The second way is classifying them as emergency or elective, and then all other cesarean sections in between. So emergency cesarean section are called type 1 cesarean sections. then elective cesarean sections are called type 4 cesarean sections. And there are those cesarean sections that need to be done within 2 hours to 12 hours, but don't need to be done right there and then. Those are called type 2 and type 3 cesarean sections. And then we have type 4 cesarean sections. Those are cesarean sections that are done at the time that is convenient for the surgeon and at the time that is convenient with the mother. So those are the ways that cesarean sections can be classified. The World Health Organization wants us to classify cesarean sections using what is called the Robson criteria. Robson criteria. So the Robson criteria classifies scissors into 1 up to 10 categories. So this categorization uses normal labor ward information. So why WHO is doing that is that we can all use the normal information that we get from women in labor ward to classify cesarean sections, and therefore we can compare who's doing what cesarean sections and for what indications. We can compare rates, we can compare prevalence of cesarean section objectively, because we are all using the same information to classify and calculate the prevalence of cesarean section. So this is something that that we can look up. So the next thing that we are going to talk about is we already talked about risks of cesarean sections and benefits of cesarean sections. So we are just going to highlight risks of cesarean section, of CS, in our setup. So the first risk of cesarean section we know is bleeding. Postpartum hemorrhage. We know patients who undergo Caesar bleed more than patients who go for vaginal delivery. The other risk for cesarean section is infection. Once our infection prevention procedures are not up to scratch, so many patients come back with infected cesarean section wounds, others come back with peritonitis after cesarean section, and so on. So infection is a big risk. So these are like immediate complications. The other ones are bowel injury. Somebody can have bowel injured during a C-section. Somebody can have bladder injury during a C-section. Somebody can have ureteric injury after a C-section. This has happened before. Then there are other long-term risks which are really associated with the weakness that has been created in the uterus. So you might have a difficult cesarean section in the next pregnancy, which can further make these injuries more likely. You can have adhesions, making the surgery difficult and making visceral injury more difficult. You have a higher risk of ending up with a ruptured uterus. We know ruptured uteruses cause a lot of bleeding, they cause fetal deaths, and in our setup the risk of rupture is around 1%, which is quite high. So these are the common risks of cesarean section for the mother. For the fetus, the problem is that the fetus does not go through the bony pelvis, and therefore the fluid in the lungs is not extracted during that delivery. So babies with born by cesarean section have a high respiratory morbidity. They have a high risk for transient tachypnea of the newborn, they have a high risk of respiratory distress. So if we are doing an elective cesarean section at less than 39 weeks, then we would need to give dexamethasone to reduce the risk of transient tachypnea of the newborn and reduce the risk of cesarean section. What are the benefits for cesarean section? So the benefits of cesarean section, of course, are that you don't end up with any risks of things like fistula, risks of all those fourth-degree tears. Patients will not have fecal incontinence risk is reduced. Urinary incontinence risk is reduced after a cesarean section. There's a risk for fetal death from fetal distress because our monitoring during labor is very poor. No one is listening to the fetal heart every 30 minutes as prescribed. No one is listening to the fetal heart every hour in latent phase as is prescribed because of shortages of midwives, shortages of other healthcare staff. The mothers are poorly monitored, and therefore there's an increased risk of those babies dying during labor. And you know that we have a lot of stillbirths and admissions to NICU after labor. So the fetal benefits are of course already prescribed. As the baby goes through the rigid bone knee pelvis, a lot of fluid is removed from their lungs, so they really breathe better than babies born by cesarean section. So that's briefly about the risks and benefits. So before we do a cesarean section, finally, we always need to explain to the mother the risk benefits as we've described. We need to make sure we get consent. The mother understands what's going on, and usually we do those preliminaries, full blood count. We have a full blood count usually, and we usually cross-match the patient because of the risk of postpartum hemorrhage and so on. So the preparation is really important for the patient to end up with a good outcome. Another thing that is important before a cesarean section is done is deciding who does what particular cesarean section. So cesarean sections are different. They might be a bit difficult, they might be easy, so it's important to decide who is going to do this particular cesarean section. So we've talked about cesarean section today. So the important thing now is just to go to theater, observe the whole procedure from where the surgeon scrubs in to where they remove the baby, and the midwife receives the baby, and so on. So that reminds me of one problem with cesarean section, which is that there's reduced bonding that happens if a mother has cesarean section, because she's nursing her wound, she gives another person to nurse the baby, and that kind of reduces a bonding with the baby, because the mother has to nurse her wound before she pays attention to her baby. Breastfeeding is started later because after birth the baby is separated from the mother. The midwife carries the baby to labor ward because the baby comes out after 2 minutes or so, and the mother is there for close to 45 minutes. So the mother and the baby are separated, and that reduces bonding. We know that breastfeeding should be done within 30 minutes of birth of the baby. So that was our presentation about cesarean section today. Thank you.